Okay, thanks for coming back. This is part two of the presentation. Again, my name is Hannah Roggenkamp, and I'm a psychiatrist at the VA in Connecticut, United States. Next, we're going to be talking about medication treatment approaches and intervention treatment approaches to PTSD. This is not going to be a lecture about therapy. I believe that will be covered by somebody else. But let's get going. I also want to mention that I won't be covering safety of medications in pregnancy and during lactation, but I have a chart at the end of the presentation that I'll just go through slowly. So you can pause if you need to, that has information about safety in pregnancy and lactation for each of the medications that we're going to be talking about. So first, I want to talk about a medication called prazosin. It's an alpha-1 adrenergic receptor blocker, and you can see it with the red box around it here. It's a postsynaptic receptor, so it blocks that receptor, prazosin does, so that adrenaline can't enter and further signal. You will also see the alpha-2 adrenergic receptor. It's up in the right-hand corner of that diagram, and that's the receptor, that yohimbine axon that we talked about in the last lecture. And alpha receptors are available all over the body. They are in the walls of blood vessels, causing constriction. They are in our pupil, causing dilation, in our bladder, urinary retention, and also they're involved in ejaculation. And we have the alpha-2 receptors that are in our presynaptic neurons. So they're in a lot of different places. And I want to mention, because I'm not sure now if I put it on the next slide, but we use prazosin and other alpha-1 receptor blockers as sort of blood pressure pills, but also to help with urine flow in people with enlarged prostates. So again, prazosin is an alpha-1 adrenaline receptor blocker that does cross the blood-brain barrier, right? So not all medications that aren't psychiatric medications cross the blood-brain barrier, but prazosin does. And what it can do is it can make nightmares go away. It can reduce or eliminate anxious awakenings, and it can overall make sleep more restful for patients. And it makes sense, right? For patients with PTSD, they have a lot of adrenaline working all over their body, and the prazosin can help block that and prevent that. We start at 1 milligram, and the way I do it is I increase by 1 milligram every 3 to 4 days until the patient says nightmares are gone. Or if they say, because it's a blood pressure pill, gosh, my blood pressure is dropping at night or in the morning, it's staying low, I'm feeling dizzy. That usually goes away after a couple days and the body adjusts. But if it doesn't, then I tend to go back down to the lowest effective dose, or I try another medication that I'm going to talk about in a second. And you can, if a patient likes the nighttime dose, you can always add a daytime dose or even a 3 times daily dosing, usually at smaller amounts than at night, for that daytime adrenaline. As far as, this is a blood pressure pill, so there's no very clear specific cutoffs of when you wouldn't start it. But I would say if somebody had a systolic blood pressure less than 100 and a diastolic less than 60, and they had kind of dizziness, then I might not necessarily start it. But if they have a low blood pressure, I might still give it a try as long as they're not already getting dizzy just on their own. And the biggest important thing that I'm going to highlight on the next slide is do not be conservative with your dosing. You want to increase until the nightmares are gone or the patient has side effects that don't go away. And according to a meta-analysis from 2024, prazosin is the most effective treatment we have, most effective medication for insomnia, nightmares, and poor sleep quality in PTSD. And probably, right, it doesn't work for everybody, and we can't predict who it's going to work for. But probably in people like I talked about with that study with the yohimbine, who have that noradrenergic driver, to their symptoms, these are the kind of patients who would potentially benefit from something like prazosin. And again, the dosing matters. I just want to bring this up because this is so important. And I see people make this mistake here in the US all the time. But this is an effective medication for the right patient, I promise you. On the left here, we have a figure from the study by Murray Raskin et al. That's a research group up in Washington State in Seattle, who also work for the Veterans Affairs. And they do a lot of work at there's a really large joint base, Army Air Force base there called Joint Base Lewis McChord, and they do a lot of research studies there, including some that I participated in when I did my fellowship. But on the x-axis there, you have time by weeks, so a total of 15 weeks. And on the y, you have the CAPS, the clinician-administered PTSD scale nightmare item. And the prazosin group is in blue circles, and the placebo is the red triangles, and very clear difference as you get to higher doses for the prazosin group as far as nightmares and nightmare severity. But the reason this study worked is because of how high the evening doses were. So you can see the kind of dosing schedule here, that men could get up to 20 milligrams at night by week 6. And for women, they recommended just about up to 10 milligrams. I routinely have patients at 20 milligrams or above. The most I think I've ever prescribed milligram wise is 45. But in that study, the mean dose for men was 15 milligrams at night and 4 in the morning. I believe for women it was 12. But so do not be shy with your dosing, right? Like keep going as long as they can tolerate it and they're not having side effects. So if we're thinking about who do I want to give this to, the question is, can we predict who will benefit from it? And the short answer is no, but I do have my colleagues, especially at the VA in Seattle, Washington, who are working on this. But Murray Raskin and colleagues did look at their data in more detail and published a paper in 2016 for the prazosin patients. For every 10 millimeters of mercury higher their standing systolic blood pressure was, so the higher the blood pressure, the resulted in an additional 14-point reduction on the CAPS-4. So that has I think like 120 points. It's a higher score, but still they had a bigger reduction. The higher somebody's blood pressure was, the bigger reduction they had. So you can think that perhaps high blood pressure is telling you, hey, noradrenergic system, adrenaline's going super high for this patient. Let's give them something that blocks it. So if sometimes I'll usually peek at somebody's vital signs if I'm going to be prescribing prazosin. If I see a high blood pressure, it's like the only time seeing a high blood pressure makes me feel good and hopeful that maybe the prazosin will help. 2 other things to know about prazosin. 1, it can help with post-traumatic headaches. Another study coming out of the VA in Seattle, especially in patients who have blast exposure. So it can help with that. Keep that in mind. Same dosing as for nightmares. And then doxazosin is another alpha-1 adrenergic receptor blocker that crosses the blood-brain barrier and is equally as effective for PTSD. It tends to be tolerated better because it's longer acting. So I have patients who get dizzy with the prazosin, but they don't get dizzy with the doxazosin at all. So if you have access to it or a long-acting alpha-1 blocker that penetrates the blood-brain barrier, definitely give it a try. I'm also thinking about your population. You might have patients with alcohol problems, and prazosin can be helpful for that as well. So one placebo-controlled study from 2018 by Tracy Simpson, another VA in Seattle, a study with 30 participants, 30% of which are veterans. The patients who got prazosin compared to placebo had fewer drinking days, fewer number of drinks per week, even if they just had alcohol use disorder and didn't have PTSD as well. And then again, the Seattle VA people, Murray Raskin, they gave prazosin to active duty Army soldiers who were already doing an alcohol treatment program. And the people who had comorbid PTSD in the study, they had fewer cravings with the prazosin. And the people with an elevated heart rate, regardless if they had PTSD or they just had alcohol use disorder, Taking prazosin reduced standard drinks per day, percent of days drinking, and reduce the percent of days of heavy drinking versus placebo. So if you have a patient with PTSD and alcohol use disorder, prazosin can help with actually drinking less. And one of the things they noted too, this study was soldiers who were in an alcohol treatment program. And the last 4 weeks of the study, the program had ended. And in the people who had elevated cardiovascular measures, right, the high heart rate, the high blood pressure, for the guys with the high heart rate, high blood pressure, and women and service members, the people who were on prazosin, their drinking didn't increase. The people on the placebo, drinking came right back up. So we know that the prazosin had an effect on their drinking for the people with the high heart rate. But really, honestly, any medication that has noradrenergic activity, crosses a blood-brain barrier, is worth considering. We talked about prazosin and doxazosin already. Don't forget about propranolol. It's a beta adrenergic receptor blocker. Doses between 10 and 120 milligrams. If you get to 60 milligrams, there's an extended release version here in the US that patients like. There have been a couple studies actually of giving patients who are going to do a trauma therapy, give the propranolol right before the session to make the trauma therapy easier to handle. Sometimes it works, sometimes it doesn't. And we've used that propranolol more for daytime, not necessarily for dreams, but something to consider. I also want to put a plug in for clonidine, 0.1 to 0.4 milligrams at night. I've had a couple patients who couldn't tolerate prazosin or doxazosin, or who had comorbid obsessive compulsive disorder and Tourette's tic disorder. And I've had success with clonidine for nightmares with them. So think about it. Just so that you know, fun things you can experiment with. I would really caution you against using the medications of benzodiazepines. They usually end with am. The ones commonly used in the United States are lorazepam, clonazepam, alprazolam, diazepam, and chlordiazepoxide. Others used outside the US are bromazepam, because they are not effective for PTSD. And this is based on a meta-analysis from 2015. And why do we think that is? I mean, we think that just the physiology underlying PTSD is just not the same as a physiology that underlies panic or anxiety disorders. But they're also not good for sleep. I know we want to prescribe them to patients for sleep, but they don't really seem effective. And one of the concerns we have is that benzodiazepines interfere with reconsolidation, right? So they're the medications when we're going into surgery a lot of the time. So they hinder the processing of memories, and they most likely hinder recovery. And one review showed that receiving benzodiazepines in the aftermath of a potentially traumatic event actually may increase the risk of developing PTSD. So do I use them every once in a while in my patients? Like if nothing else is really working, for just very occasional use, once a month, twice a month? Absolutely. But they're really just not suitable for more regular, routine, consistent use. Next, I want to talk about Z drugs. They're short-acting GABA agonists, meant for the short-term treatment of insomnia, not chronic insomnia, which is more what we see with PTSD. But here's a little figure of the GABA receptor there. It's a chloride channel, and the Z drugs can keep that open. There's zolpidem, zopiclone or S-zopiclone, which was in one study found not effective for sleep or for PTSD versus placebo, and then zaleplon. The risks with these meds are falls, anterograde amnesia, so inability to form memories. We see hip fractures in older people, sleepwalking, sleep driving, motor vehicle collisions, really pretty serious issues. And I really am very cautious about these medications in patients with PTSD, because patients with PTSD tend to have higher rates of what's called REM without atonia, so rapid eye movement sleep, where their body is not paralyzed and they can move around. So taking one of these Z drugs can actually increase the chance that that moving around results in sleepwalking. And the other reason I don't like these is, man, it's really hard to get patients off of these drugs. So I just try not to start them ever. What are we going to do instead? So there are some non-Z drug, non-benzodiazepine sleep aids to consider. Of course, we want to avoid anything with an antihistamine or anticholinergic qualities. What those are, I'll mention them again on our one of our subsequent slides. But we want to avoid those in the elderly because of side effects, but there are some we can consider for folks. So one is doxepin, and you can start anywhere from 3 to 10 milligrams and increase as tolerated. This is, again, something where we worry about anticholinergic side effects in elderly. Trazodone, where I typically start as low as I can, 25 milligrams, and maybe increase by up to 300. But you want to watch for dizziness, and also patients tend to feel, a certain number of patients tend to feel really exhausted and tired in the morning. So that kind of limits some of what we can do there. There's also a medication called gabapentin, which can be helpful for pain and anxiety and for sleep. Start at 100 milligram. The max one-time dose you can do is 1600, and the max is 4800. So a lot of range there. And again, it's helpful for pain as well. Mirtazapine, where you start at a low dose. One of the ideas is that the lower doses are more sedating than the higher doses. But we have to watch for weight gain there. And then melatonin, where we typically start at 3 milligrams. And it's really not advised to go above 10 milligrams with melatonin. Next types of medications, the selective serotonin reuptake inhibitors. Are these the meds for the people who have a serotonin component to their presentation, right? So I mentioned the VA Department of Defense clinical practice guidelines, the CPG. So they have 3 of these types of medications that they recommend. One is sertraline or Zoloft. The other one is paroxetine or Paxil. The third one is on the next slide. But other SSRIs are citalopram, escitalopram, fluoxetine, and fluvoxamine. Personally, I think these all are kind of like equally maybe effective for PTSD. Unfortunately, as you all probably know, it takes at least 6 to 8 weeks at a dose to really know what it's going to do. So that takes a lot of patience. And of course, patients have to take them every single day. Skipping doses just makes it more difficult for the medications to work. Here you see a figure of how they work. The SSRIs work on that serotonin autoreceptor there, so it blocks the serotonin from being reabsorbed, and it works in the cleft longer. There are actually very few placebo-controlled randomized studies of SSRIs in PTSD compared to active treatment. And the positive studies tend to be done in civilian PTSD, not in combat PTSD. And they might actually work better in women than in men. Most common side effects you probably know about are sexual dysfunction, feeling numb, that kind of thing. And I don't really have any recommendations for dosing with any of these studies. But I think what they can help with is feeling lighter, less stuck, that kind of thing. Other antidepressants are the serotonin and norepinephrine reuptake inhibitors, SNRIs. And one is venlafaxine, which is a clinical practice guideline recommendation, and duloxetine. There's also mirtazapine, which I mentioned earlier. Nice thing about mirtazapine is an antidepressant, but it actually doesn't have sexual side effects, unlike the SSRIs and SNRIs. But it can cause sedation and weight gain. And then bupropion, which is brand name is Wellbutrin. I actually use a lot for depression, but what I've noticed, it can give people energy. And for people who have anxiety already, it's like a little too much energy. So you just want to be careful with those patients. And there is also an increased risk of seizure just because of electrolyte issues. It's still a small risk, but a risk nonetheless that you have to be aware of. So these are other medications to consider. And I've become more recently a fan of the venlafaxine because there was a retrospective chart review of 834 VA patients and found that the SSRIs, the topiramate, which we're going to talk about in a second, and then venlafaxine all led to similar kind of PTSD symptom reduction, but venlafaxine was more likely to have patients get remission, so the PTSD diagnosis loss, than the other medications. But again, it's not clear that any of these drugs are super extremely better or worse for PTSD. And really, the effect size we see in the reviews and meta-analyses are relatively small of negative 0.28. Next, I want to talk about tricyclics for PTSD, tricyclic antidepressants. And these are kind of good. I know they're the older antidepressants that, at least here in the US, we don't use quite as often, but they're really nice also for patients with migraine headaches and who have chronic pain, which I'm imagining some of your patients have, so worth considering. There's amitriptyline. You start at 10 to 25 milligrams. The max dose is 125, and it is the most sedating, so you have to be aware of that. The least sedating is nortriptyline. Again, you start at 10 to 25 milligrams, and the max dose is 150. This can be helpful for, again, these medications can be helpful for PTSD and anxiety symptoms. And then there's dazipramine. Again, starting dose is 10 to 25, but the max is 300. And it might be especially effective for people who have comorbid alcohol use disorder, and according to one study done here at the VA in Connecticut. But the thing about tricyclic antidepressants, there's the anticholinergic side effects. So constipation, dry mouth, blurry vision, urinary retention, palpitations. So you could see where, especially in older people, we don't want them to retain urine. That can cause urinary tract infections. So this is why we want to be careful with the anticholinergic drugs for elderly folks, especially. And it's worth considering an EKG before starting because it can affect the heart rhythm. And because it can affect the heart rhythm, we really want to be careful in people who are suicidal, because if we give them a larger amount of pills, they can use that to have a fatal suicide. So we want to just be careful with those types of patients. But tricyclics for PTSD, think about it. Couple more medication classes here. Next is antipsychotics. You can consider them for symptoms like paranoia or kind of that emotional instability. One to consider is risperidone or Risperdal. The effect size as an augmentation to treatment. So you add it to treatment that the patient already has, a medication treatment, for example. The effect size is negative 0.24, so like a small effect size. We start the dosing low at 0.25 milligrams. There's quetiapine, which I think we use a lot here in the US. There's only one study about global symptom improvement in PTSD with quetiapine. You start at 25 milligrams, and the mean doses in most of the studies are between 100 and 300, but it's very sedating, so we use it especially for sleep. It's probably the most effective antipsychotic that we have for PTSD, according to the studies, with an effect size of negative 0.59. Then there's olanzapine. We don't have a lot of data on that. And it's causes severe weight gain in many patients, so worth avoiding if you can. The last one I want to mention is aripiprazole, and there have been no randomized control trials, but there have been open label studies that were positive. And there's no studies for haloperidol, lurasidone, or ziprasidone. Problem with the antipsychotics is just the long-term effects. We're talking about weight gain, metabolic syndrome, which we're going to talk about a little bit more on the next slide, but also the tardive dyskinesia from long-term antipsychotic use, and also extrapyramidal symptoms, Parkinsonism, that kind of thing. So personally, for me, I try to avoid them if I can, but when we do want to use them, we want to have a really good reason for doing so. And why is this? It's because PTSD is really hard on our body. PTSD is linked to acute cardiac events and to stroke. You can see this on this really nice figure that was translated for me, looking at PTSD symptoms in that left-hand column. And then in the middle, we see how the dysregulated cardiovascular physiology, blood pressure being affected, heart rate, which can lead to cardiovascular morbidity and cardiovascular mortality because of PTSD. And we've linked metabolic syndrome to PTSD patients. And there was a really good meta-analysis on this from 2015. And metabolic syndrome is a constellation of risk factors: central obesity, high blood pressure, low high density lipoproteins, so low HDL, elevated triglycerides, and also hyperglycemia, high blood sugar. And we found metabolic syndrome in PTSD patients, 38% prevalence in PTSD. 49% of patients with PTSD had abdominal obesity, 76% had hypertension. We've talked about that. And having PTSD almost doubled the risk for metabolic syndrome. So it's so, so, so important that we, of course, treat the mental health issues, but we also really monitor blood sugar, weight, all that stuff to keep these patients as healthy as we possibly can. Last medication I want to talk about are mood stabilizers. And I think they're not going to treat PTSD symptoms per se, but they will help with anger, explosiveness, irritability. We got topiramate, which has the most data, overall effect size on PTSD symptoms of negative 0.57. And it's also useful for headaches. We use it for that. But the cognitive side effects, it makes people feel very, very dull, kind of loopy. So it's not always the best choice. There's also lithium. We don't have any randomized control studies for PTSD, so we don't really know the effectiveness. Now, personally, I would consider these drugs if somebody has bipolar disorder as well, then it's worth using them, of course. Divalproex, there's limited studies, mixed results, and we always have to worry about things like weight gain affecting the liver. And then lamotrigine, where we don't have any studies for PTSD, but patients tend to tolerate it well, no real weight gain concern, and personally, I use a fair amount of lamotrigine for my patients. The last thing I want to do is talk about other interventions to treat PTSD besides medication. So the first is stellate ganglion block. First, I'm going to tell you about how it's done and some of the science behind it, and then I'll tell you a little about what it can do. So stellate ganglion block has been used for over 100 years on sympathetically mediated conditions like complex regional pain syndrome, migraines, hot flashes, etc. And it's injecting a local anesthetic, usually ropivacaine or bupivacaine, into the central sympathetic chain or the stellate ganglion to temporarily block the stellate ganglion's function and to inhibit sympathetic nervous activity. And it's right near the sort of C6 level on the right side, usually. And that's right side's been favored because of that hemispheric symmetry, asymmetry, sorry, a theory of autonomic arousal. But some people advocate for injections on both sides. The needle is guided by ultrasound or fluoroscopy in the anterior paratracheal area or the lateral approach. Most of the studies, a lot of them only provide one injection. Sometimes if you see symptoms come back a little bit at 4 weeks, so they get an additional one. In one major randomized control trial, they gave a second shot 2 weeks after the first one. And there's some studies that give a left-sided block 24 hours after the right-sided one if the right-sided one doesn't help. So there's a lot of different ways to do this. And we usually see symptom relief after as quick as 5 minutes. So patients will tell me, the ones who have had success with it, doc, it was like a switch flipped and I felt different. It was immediate. So when it works, it can be very, very powerful. The minor side effects are cough, hoarseness, lightheadedness, pain, stiffness at the injection site, and then a Horner syndrome that's temporary. That's actually a good thing when we see it. That means we really got in there with the injection. More severe side effects are rare, extremely rare, 1.7 complications per 1,000 blocks, but includes seizures, brachial plexus block, subdural or intraspinal blockade. But you can minimize severe side effects by proper needle placement. So how does it work? There's this proposed mechanism through the nerve growth factor, because nerve growth factor increases as a physiological response to both acute and chronic stress. And you see nerve growth factor increase in the stellate ganglion. That leads to neurite outgrowth sprouting, and you get new nerve growth at the end terminals. And this sprouting is hypothesized to lead to an increase in cerebral norepinephrine levels, thereby producing anxiety-related PTSD symptoms. And we know that local anesthetic injections are actually known to suppress nerve growth factor, leading to the dying off of new nerve outgrowth and sprouting, and that's hypothesized to reduce norepinephrine levels. And this reverses this PTSD cascade. So it's actually through this nerve growth factor that it seems like it works. So what about the data, right? So there was a case series in active duty service members with severe PTSD. This was probably the big kind of introduction to this intervention. And at 1 week follow-up after the injection, 80% had a 22-point average reduction on the PCL. That's a huge, for a PTSD study, that's a huge, huge, huge change. So that was a case series in active duty military service members. That was very positive. There was a 2020 randomized control trial where they got 2 injections 2 weeks apart with the effect overall of minus 0.56, a pretty moderate effect. What the people who do this intervention have noticed is that the more severe a patient's PTSD symptoms are, the bigger response it is that they might have. The symptoms most likely to remit are hypervigilance, concentration problems, sleep disturbance, physiological reactions to trauma, and emotional reaction to trauma cues, as well as intrusive memories. But there's no effect in about 10 to 20% of patients. We haven't seen a lot of like longer term follow-up, but the longest follow-up seen in one study was 6 months, and we saw like a little uptick in symptoms, but the symptoms didn't return all the way to the pre-block levels. And it may be more effective in like military-related PTSD compared to civilian PTSD, no matter the gender, just something to know. And it may also help with post-concussive symptoms related to a mild traumatic brain injury. So there's other approaches where you can do a block at C4 and C6, but those get a little bit complicated. There was a study published in 2024 that talked about it. Also ketamine for PTSD symptoms. A lot of the ketamine research on depression was done here in Connecticut, but ketamine is an NMDA glutamate receptor antagonist that has antidepressant properties, and it can give rapid relief for depression symptoms and suicidality. The problem is when you give it, it can cause dissociative symptoms, blurry vision, dizziness, headache, nausea. It can be very hard to tolerate. In one patient study with PTSD, participants got 6 infusions over 2 weeks, but the response was gone 2 to 3 weeks after the last infusion. Most studies use IV ketamine at 0.5 milligrams per kilogram. And there was a meta-analysis for PTSD symptoms from last year that showed an effect of negative 0.25. So not all that impressive, honestly. Finally, my last slide, I'm going to talk about other interventions for PTSD. And I apologize. I think the translation for the last 2 points got missed. It just happened. So I hope you can I'm still make myself understood. Exercise can be really effective for PTSD symptoms. According to one analysis, the effect was negative 0.46. So like a moderate effect, pretty good. And had a negative 0.51 effect on sleep, also pretty good. There's some research on high-frequency transcranial magnetic stimulation, or TMS. They give 11 to 19 sessions over 2 to 4 weeks, but you need to give the treatment continuously, otherwise they relapse. But you see that effect, negative 1.17, huge, but you have to give it repeatedly. There's also MDMA-assisted psychotherapy. We're very interested in this here in the US, and I know all over the world. But there's just a lot of questions about the methodological issues and how the studies were run. So I wanted to give you the information that this is a thing, but we just need more studies done on it by other institutions. In one study from 2021, the effect was negative 0.91, big effect. And a second study in 2023, the effect was negative 0.7. So again, pretty high. Last, hyperbaric oxygen. There's no quality placebo-controlled trials, but there have been some small decreases in the PCL scores, but this is after 40 to 60 hour-long sessions. Your patients might be getting hyperbaric oxygen for wound healing, that kind of thing, inflammation, so just worth knowing. The next slides here are my pregnancy and lactation slides. This is for informational purposes only. I'm just going to spend a second or two on these slides. I'm going to go through them. And feel free to pause on these if you're watching this presentation. I have some recommended reading. It's listed here, just about PTSD treatment and things in general. There's so much other stuff I would recommend reading. And again, all my references are at the end. So thank you so much. It's been just an honor to be able to present to you, and I wish you all the very best in the future.